Hi, everybody. We're about 4 minutes out of starting, and I just wanted to welcome the folks that are on the call. We're going to start in about 4 minutes. Thanks. And we're going to get started. This is Lori Delagrammaticus from the California Department of Social Services. I'm the APS liaison here at the Department of Social Services, and this webinar is going to cover what social workers need to know about the new SOC 242. So it's going to talk mainly about what you need in terms of case documentation. You are all on mute because we expected quite a large crowd, as well as the fact that we're trying to record this so that we can post it on the internet for anyone who missed it. I know this is the holiday season and some people may not be able to attend. So because you're on mute, if you have questions, you can type them in the chat box on the right-hand side of your screen. I am here by myself, so I will try to answer them as I see them and as I become aware of them. It may be kind of out of order at the point of time where I actually see them. Again, everyone's on mute. I do not have anybody providing technical assistance. If you find you can't hear me or there's a problem along that lines, your best bet is going to be to hang up and to come and clear and click out of the webinar and then come back in. Generally, that fixes most problems. All right, so let's go ahead and get started. So what is the SOC 242? You know, line social workers probably are not dealing with this on a regular basis, but this is a report that the counties prepare and send to the state every month. It's the only way the state gets aggregate data from the counties. And it includes things like how many cases did we open, how many cases were closed, how many self-neglect cases were confirmed, how much abuse was perpetrated by others, and so on. So it's really all the information about the work you do that comes to the state of California. So why is it important? I know you guys really don't, data is not the thing that drives you in your work every day. And having to fill out a lot of documentation is probably not your favorite thing, but it really is important. A lot of the data helps us to ask for funding for adult protective services by knowing how many cases you're having to deal with, how much abuse is actually being perpetrated. We can use those for advocacy efforts to help get APS funded. It also helps determine how much staff we need and what kinds of services are needed. And researchers are really interested in APS as well because they want to know what's effective in addressing abuse. So there are a number of reasons why we really need this data. So let me give you a little bit of background. I guess now it's 3 years ago, the Administration for Community Living, which is the federal home of Adult Protective Services, provided grants to the states to improve their data collection systems, and California got one of those grants. And as part of that effort, I worked with a committee from PSOC to add in the NAMERS, which stands for the National Adult Maltreatment Reporting System, data elements to our SOC 242. And because we were adding a bunch of elements, one of the things we decided is we needed to also get rid of any data elements that really weren't being used. So we did a lot of work in terms of surveying the counties and our community partners about what data they used. And we tried to take out anything that didn't seem like it was being used by a large number of people. We also added a couple of data elements. I think about 10 total that the PSOC committee thought were over and above what namers were asking for that they thought would be useful. So one of those, for example, that we'll come up to is hoarding. How many hoarding cases are you dealing with? Because we know those are really tough cases. They're time intensive, and we wanted to capture that. So there, we did add a few things above and beyond namers, but not a lot. So the point of this webinar is to make you aware of some changes that don't directly affect you, but are important for you to know. So for one of the big ones is we're now going to be collecting information about how many APS workers, managers, intake workers are in the state of California. As your representative at CDSS, I often get asked, what do caseloads look like? And not knowing how many workers there are in the state, because at this point, I don't have that information unless I do a point-in-time survey of the counties, I can't answer that. So we are now asking on the SOC 242 that counties report how much staff they have. The change you may see is in your case management system, it may ask you for what your job position is when you initially set up your account. And that's the reason for that change. We really want to be able to get to caseloads. Some of the other things we've added are changes in definitions and changes in what we need you to document. And that's really the gist of why you're on this call. We're changing some definitions, we're adding some new things that you're going to have to document, and you need to know what they mean. So one of the new categories is the reporting source. So we're asking you to tell us who made the report. And this is probably going to affect intake workers the most. And a couple of these definitions are a little bit tricky. So for example, a professional service provider is someone who's in the business of working with older adults or with persons with disabilities. So people like your regional center, folks at the Office on Aging, those kind of people would fit under professional service provider. A community professional, which is the fifth one down, is a little tricky. A community professional is someone who encounters the client in the course of their job, but their job is not directly around elders and dependent adults. So this is your hairdresser, your mail carrier, your real estate agent. Those kinds of folks fit there. One of the ones that I think you're going to be surprised about is no relationship. If they do not fit one of these categories that you see here, we're going to put them in the no relationship categories. And that's going to include friends and neighbors, which seems a little odd, but that's how Namers has set this up. So we're going to encourage you to mark as many categories as are appropriate, and if your system allows it. So we've got the example here on the screen that a conservator could be both a social worker and a mental health expert. The reason we're doing this is we're less interested in how many reporting sources there are than in who's making reports, because that's going to help us figure out who do we have to do outreach to, who do we need to provide more education to, and so on, by knowing who's making the reports. This next one, recidivism, you will not be directly having to put this in, but it's related to the dates on how often we get reports and open cases. So your data system should do this, but I wanted you to know that we are now going to be able to tell you how many clients keep returning to us. Recidivism is one of those things that often case management is needed, and we would be able to use that to advocate for case management services being available for APS workers. The NTDs and the NIRs are not changed at all. And as you see here, the one exception is how to report findings when you don't have enough information on an NTD, and we'll discuss that a little bit later. But in general, there's no change in this category. One of the problems with our old SOC 242 is we were not able to figure out how many of our clients were actually victims. So now we are going to be able to pull that information out, and a victim is defined as having at least one allegation of mistreatment or self-neglect that is confirmed. So the new data is going to let us know how many of our clients actually are victims. One of the big changes for you is that the self-neglect categories have changed. Now, the definition of self-neglect is going to remain exactly the same as it has always been. That WIC code section has not changed. However, we found that the general public doesn't understand things like health and safety involving both broken ramps and suicide attempts. That didn't make any sense to folks. So we're now going to ask people to divide the different self-neglect issues into three categories. One is, are they neglecting their own physical care? And that's going to be the default if you're not sure. So, for example, someone who doesn't go to their doctor's appointments because they don't have enough money to pay the copay would be neglect of physical care, but in that case, it would also be financial self-neglect. So neglect of the person, neglect of the residents, or neglect of finances are the three categories. And the default is always going to be neglect of physical care if you're not sure. All right. So here we're going into this in a little more depth. So, and this is where I talked about the default for self-neglect is self-neglect, but it can be both self-neglect and neglect of finances. Neglect of residents is, again, negligent failure of an elder dependent adult to exercise a degree of care that a reasonable person in a like position would exercise in regards to their residents. And that's going to include most of the things that you were previously putting in health and safety. And then financial self-neglect is, again, the negligent failure of an elder dependent adult to exercise that degree of care that a reasonable person in a like position would exercise in regards to their finances. So we are putting in there, in the example, you'll see repeatedly falling for a scam after being warned that it was a scam. That one might be a little different. That's financial abuse by another, of course, but it also ends up being in self-neglect. Okay, hoarding is a brand new category, and we're defining it as the accumulation of household items and animals to the extent it poses a threat to the client, and it must be either a health and safety hazard, a fire hazard, or an eviction risk. And this includes whether the hoarding is by the person themselves or by their caregivers. Now, you're also going to end up, if it's self-neglect, it would be self-neglect of residents. It's still going in that category, or neglect by a caretaker if it's the caregiver who's the hoarder. I'm hoping that makes sense. But basically, we want you to still put all of those kinds of cases in their normal spot, self-neglect or neglect by someone else, but also count it. Click a button that says this is also hoarding. We have added some subcategories in financial abuse that you haven't seen before. This was one of the areas that our PSOC committee wanted to make sure we covered. So we have three subcategories now. One is improper use of assets, And that's going to be where you put most of your normal financial abuse by family members, where somebody's taken the victim's credit card, someone from the family's taken the victim's credit card and running up bills on it, or asking them to sign over their house or so on. But we also have outright theft, where the victim didn't know what's going on and they just got in their purse and stole cash, and scams. Scams was especially of interest to the PSOC committee. So I'm going into a little more detail here. Improper use of assets is going to be your default category for any financial abuse. And it includes undue influence and misappropriations not known to the client. Theft is going to be defined as the outright stealing from a person, and there's no relationship required to the thief. So anytime they're taking away stuff from the client and stealing. And then scams is a dishonest scheme to swindle the client out of their money. So scams can be committed by strangers, but they can also be committed by people that the client knows. For example, sometimes we have the sweetheart scams. And I think you're all aware of the various stranger scams that are out there, like the lottery scam and the grandparent scam, or the taxes scams, so the IRS one. Okay, another new category we're going to have is suspicious death of a client, and this is a new category, and it's a little tricky here because it includes reports at intake where the client has already died. You are not opening cases on dead clients. We haven't done that in the past. There's no client to provide social services to, so we're not doing it now. That will be collected at intake when the report is that someone died and they think it's the result of abuse. It also includes deaths that occurs during the investigation where it's suspicious and you think that the abuse may have been what caused the death. Do not include self-neglect deaths. You're only including deaths that involve a suspicion of abuse by another person. So we're also changing up the case closure reasons a little bit. So cases that are completed and closed have two subcategories to them. The first one is protective services completed. So this is, you did the investigation, you offered services, the person accepted services, you're going to mark that as a case completed and closed with protective services completed. If you've done your investigation, you've decided that services are needed, but the client refuses those services, that's going to be cases completed and closed, and the subcategory will be refused services. If they accept any of the services whatsoever, it goes into protective services completed. So those are your two categories when you've completed your investigation. There's another category, unable to complete, close the investigations without findings due to lack of information. This is where those NTDs go, where you just didn't get enough information to figure out whether the abuse actually happened or not. If you have enough, we don't want you to do those anymore as inconclusive. I know in the past that's kind of where people put them. If you don't have enough information to say whether the abuse occurred in those kinds of cases, we want you to put them here because you weren't able to complete the investigation and come to findings. The third reason is the client died. If the client died before you were able to do the investigation, you're going to use that as the case closure reason. And the last category is going to be opened in error. And you're going to use this if, for example, you got two duplicate reports and you opened two cases and now you've got to close one of them because you shouldn't have had to. those kinds of mistakes are going to end up with the case closure reason opened in error. That's your default if you can't, if you really shouldn't have opened a case. Cases that were opened and you found out they weren't in our jurisdiction would also fit in that category. So again, I'm going to go over this again because I think that this can be a little confusing. Protective services completed, that's all cases that were closed after the investigation was done and the client accepted all or some part of the service plan and or involuntary services were implemented. So when we talk about accepting services, this does include those cases where you put involuntary services in place. Refused cases are cases where the client refused to speak to you, but you could figure out whether the abuse occurred by, maybe by talking to collateral contacts, or also the cases where you actually finished the investigation, you figured out what services you wanted to provide, but the client wouldn't take any of those services. Unable to complete and closed without findings due to lack of information. So we want you to use this category instead of inconclusive if you really couldn't complete the investigation. So if you couldn't locate the client is the time that you would use this. NTD cases where you just couldn't get enough information. And cases, especially self-neglect cases where the client refused the investigation and you had no other way to figure out what happened. This is going to be the one you use when the client in a self-neglect case slams the door in your face and won't tell you anything. Okay, case closed because the client died. If the client died before your investigation was completed and you really don't have findings, it goes here. This is a little different than the suspicious deaths. In this case, the client could have died of natural causes, no evidence that it was abuse, but now you can't finish your investigation. It would go here. And again, cases closed because they were opened in error. When you have to merge cases is another place that would go in here. Okay, I haven't seen any questions yet, so I'm hoping this is making sense to folks. The next area that is brand new is interagency coordination during the investigation. And the key word here is investigations. We're trying to collect who does APS work with on these cases in terms of doing the investigation. So there's a catch-all place where you would mark you worked with another agency during this investigation. But then there are drop-down subcategories where we're trying to collect specific numbers. And one of them is, did you refer the case to law enforcement to do an investigation? This is not, I'm going to say that again, this is not your standard fax over the referral because you're supposed to do a cross report. This is, you called up law enforcement and said, I think there's merit to this abuse case. I'd like you to work on it with me. It's where you've actually done kind of a warm handoff to law enforcement. That one was kind of tricky when we were talking about it in committee. It really is this, you have to do at least one step of some sort beyond your standard cross report. The second interagency coordination category that we're going to, subcategory actually that we're going to ask you for is if you requested that somebody work on a capacity assessment or a capacity declaration. So if you contacted the doctor to get a CAP deck, or you got your county to actually pay for a professional assessment, we want to capture those. So there is probably going to be a new checkbox on your computer, your case management system to let you mark that that's been done. And the last subcategory of interagency coordination in the investigation is to request a conservatorship investigation from the public guardian. This is not that you got the conservatorship, it's that you referred it over to the PG for a conservatorship. We want to start keeping account of how often that happens. One of the reasons for doing that is to help build the case that public guardian needs to be a heftier program that's able to meet the needs of APS clients. And by getting these numbers, that's going to help us with that. All right. So this next piece is APS supportive services. We're going to try to count what services you're putting in place so that we have a better idea of what services APS clients need, how often they need them, and eventually whether they're there or not. So here are the categories we're going to cover. How many clients are referred for housing and relocation services? This is just the referral process. You gave them a number to call to help them with housing or to find them a new place to live. So referral only. Then there's a second category of clients who received housing or relocation services from APS. And this is when you do something beyond just making a referral. You went out and looked for housing for them. You got them involved with the Home Safe program. You made a bunch of calls to get them into a shelter. Any of that kind of work where you're actually doing the work, you want to count here. The next category is clients referred to in-home assistance. So this is anybody you refer to IHSS, getting home health aides in, getting friendly visitors in, any kind of chore service, personal care services, those kinds of things are all lumped into this category. The next one is clients referred for transportation services. And even though this says referred, it includes if APS is providing that transportation, if you're giving them taxi vouchers, that sort of thing. You're doing referrals. You're completing the paratransit application. Anything, the purpose of this category is how many of our clients need help with transportation, whether we're the ones giving it to them or not. That's what we want counted here. The next supportive services we're counting is clients referred for legal services. So this is restraining orders, tax advice. You see the list there. This would include if you are getting the APS restraining order and doing all that work there, you want that included. But it's any kind of legal services we want captured here. The next category is clients referred for ongoing case management. And you see the list here, mental health, MSSP, regional center, rep payee, any kind of ongoing case management outside of APS. Not that we do ongoing case management, but I do know there's a couple of counties that are able to provide some additional services. So this is above and beyond that. Okay, this next category about demographic information for clients, I am especially excited about, and the reason being, on the current SOC 242 at the state level, I get no client demographic information. Your counties can pull them from your case management systems to do this on a county level, talk about what your clients look like, but at the state level, I have not been able to say anything about who our clients are, not their ages, their genders, nothing. So we are now going to be collecting that information. We're going to be asking you to put in their age, and the directions do say to do your best guess, their race, And one of the questions that's come up quite often is, where do Hispanic folks fit in the race category? And being Hispanic is not a race. Being Hispanic is an ethnicity. It has to do with cultural issues like what language you speak and what culture you identify with. It is not considered a race. So you need to ask people what race they identify with if they tell you they're Hispanic. We are going to be collecting the SOG information, which is the sexual orientation, gender identity information. You should have, my guess is you've already had some training on this in your counties because this went into effect, the law on this went into effect earlier this year. The categories that you're going to see on your case management system are going to be in line with what you've already learned about. We're going to be collecting information on what clients are receiving these 5 benefits at case closure. Do they have Medi-Cal? Do they have Medicare, Veterans, SSI, or subsidized housing? We want to get an idea of what other benefits our clients are already getting connected with, so we know what's going on there. Next is clients with disabilities. Now this is in your best judgment. You're not diagnosing people, and these folks, you don't have to have an official diagnosis from a physician to say that you think your client has ambulatory difficulties or you think your client is exhibiting cognitive difficulties. This is in your professional judgment. Does this person seem to be having problems? Again, we're not asking you to diagnose. We're asking you to look at how the client is presenting themselves and using your professional judgment. For self-care difficulties, we're talking about that's the language from NAMERS, and we're talking about activities of daily living, bathing, grooming, feeding, toileting, all that stuff. And I hope that's fairly clear. We also have independent living difficulties, and that's your IADLs. That's cooking, using the telephone, doing shopping, doing housekeeping, and so on. The hearing and vision difficulties are, do they need some kind of help in terms of hearing aids, glasses, and so on, where they're still having problems even with those help. Okay. The next one is, we're going to capture how many of our clients are living outside of an institutional setting at case closure. Another way to think of that is, at the end of your case, is the client still living in a situation that would be APS jurisdiction? What we're trying to get to with this is, how much of the time are we keeping people out of institutions and in their own homes? That, one of our cardinal values is to keep people in the least restrictive setting, and we want to know how often we're managing that. So think of this as, wherever the client is at case closure, would that still be APS jurisdiction if something happened to them there? The next category we're going to be collecting is clients with a behavioral condition. And again, this is based on your observation, the information you have been given, and your best judgment. So you do not need a diagnosis. You need to either have heard information about the client or seen for yourself that the client appears to have schizophrenia or a dementia. And I would suggest that if you're going to click these boxes, in your documentation should say what you're basing that on. But there is not a requirement of a diagnosis. We're really trying to figure out, one of the big questions I get asked is, how many of your clients have a dementia and therefore are being are becoming victims of abuse? And I don't currently have that answer. We're hoping that collecting this information here will help us get there. We're also asking whether at the end of the case, does the client have a guardian or a conservator? Do not include this if it's pending, if it's a pending PG. At the end of the case, do they actually have a guardian or conservator? We're also asked, we didn't put in here what languages everybody speaks, but we are going to be collecting whether somebody needs the client needs an interpreter, or whether that you have to send a bilingual worker out there in order to effectively handle the case. So we're going to be asking you to tell us that for your clients as well. This is another new category, and some of this information you may already be putting into your case management system, but this also has never come to the state before, so we're standardizing it and asking you to provide this information. Age, if you know it, and again, we would ask for your best guess. Gender, and this can be reported by the reporting party if, we're not asking you to ask the abuser, what's their sexual orientation and gender identity. You do have to ask that to the client, but you don't have to ask that of the abuser. We're going to, if you've got a good relationship and you can ask, you can ask that here, but we're not requiring you to ask that of people. Then what's their kinship relationship to the client? And we're going to be this is a drop-down menu, has a lot of different ways somebody could be related. I'll be real honest, if they say they're family, they're family. Whether they've just lived together for years and they're not really a stepchild or adopted child or whatever, but they've been part of the household for a long time and they consider themselves family, they're family. And that, by the way, that also goes for a reporting party. If somebody thinks they're family, we're going to accept that. Then the next category is, do they have other association with the client or no association? So this includes various professional ways that somebody might be involved with the client. I'm trying to remember what the categories are because I didn't write them down here. I'm gonna refer you to the FAQs that I sent you when you signed up for this webinar. And if you're listening to a recorded version of this webinar, because it is being recorded and will be up on our website, the FAQs will also be posted on the website. So you're going to be looking for those. Okay. We're also going to ask whether the client currently lives whether the perpetrator currently lives with the client. And this is at the time the abuse occurred, because sometimes people move in, move out, and you're not sure. Okay. And we're also, just as we ask for the clients, we're going to ask for the suspected abusers. Do they have a behavioral condition? And we've kind of lumped these together: psychiatric mental health disorders, addictive disorders, or organic brain disorders. So, schizophrenia, bipolar would go in your psychiatric mental health disorders. Addiction is going to be alcoholism, substance abuse, gambling, all of those kinds of addictions. And organic brain disorders is going to be your traumatic brain injuries, and that's where you're putting dementias if the suspected abuser has dementia. Okay. It looks like we got some questions, and I've been rolling along. Will the SOC 341 be revamped to match this new self-neglect categories? Yes, and that has already been done, and the new SOC 341 all-county letter will be coming out very soon. when you see it, you will notice it's in a lot bigger font because it's now accessible. It takes a lot more pages because of the bigger font. It's going to include the sexual orientation, gender identity questions, the race and ethnicity questions, the changes in the self-neglect categories. And one of the big changes is that probably nobody else will notice is at the end of the instructions, the Bureau of Medical Fraud asks us to put in a notation that no one can keep a mandated reporter from making a report, and if they do so, please report that to law enforcement. So that will be there as well. So those should be coming out fairly soon. Okay, the next question. What if the hoarder is a family member, non-caregiver living with the client? And in that case, we are counting that as a hoarding case. And probably if they're not a caregiver, then it would be a self-neglect case where the client is not handling the fact that the non-caregiver is hoarding. The next question is, what if some findings are confirmed and some findings are inconclusive for the same ROA? I'm not sure what ROA is. Dana, can you go in and tell me what you mean by ROA? We are handling findings by allegation, so you're going to confirm the allegations that are confirmed and make inconclusive the allegations that are inconclusive. If the client died during an investigation for whatever reason and there are findings, you're going to confirm the findings, and you're not going to report that the client died without completing the investigation. Okay. In case completed section, I am assuming that on a visit when the client cooperates with the APS interviews, but it's determined that no services are needed, the section would be protective services completed. Yes, that is correct. If there aren't any services needed, you've done everything you should have done, we're going to call that a totally completed case. So it would go into that the case was protective services were completed. What if a client accepts some interventions but refuses others? As long as they accept some of the services, it's going to go into protective services completed. Do home-based services include case management, referral, and pest control? Pest control. I don't think we would include pest control. We probably would include case management. I would refer you back to the FAQs, and if that still doesn't answer that, Dana, if you would shoot me a question. Our FAQs are going to be a living document. The plan is, as we start rolling out this SOC 242 and questions come up, we're going to address those questions, put them in the FAQ, and repost it on a regular basis so that all the questions and answers will all be in the same place. So SSI or SSDI, it is SSI that we're asking you to report. Are these new demographics on intake or at assessment? So at intake, you're going to, so for example, the SOG information about your clients. When someone calls in a referral, you're going to ask them what gender the person is. And let's say they say the person is female. When you go, you're going to put female on there for the time being. But when you go out to see the client, you do need to ask how they want to be self-identify. And if that's different, then you need to change that at that time. And that pretty much goes for any of the demographics. If they need to be changed, then you will need to change them. But the intake process, we still want to know, when I knock on the door, am I expecting to talk to a woman or a man? If nothing else, you use the right pronouns, or what you think are the right pronouns at the time to get started. With a lot of this stuff, you have to have some kind of starting place. But if they need to be updated, you will need to do that. What is the value of accepting non-family AAs as family? Often that's part of the abuse. Again, we are just trying to capture how people are seeing themselves as related. And I would say, if the client thinks of them as family, call them family. I guess I wasn't very clear about that. If the client doesn't think of them as family, then don't. But if they're trading on that as some kind of a family relationship, you need to keep that. Is this presentation available for download? I did send it out to everyone who had registered. If you didn't get a copy of it, you can send me an email and I will send it out. Do social workers ask for the age of the abusers or just guess if unable to ask? That's correct. We want your best guess. And frankly, for the SOC 242, we're dividing it into to 5 and 10 year increments. During the younger ages, it's 10-year increments, and in the elderly, we're doing it by 5 years increments after 65. So your best guess of the range is going to help us. Can you email this PowerPoint to attendees? I thought I did. Maybe I just sent you the FAQs. I can send out the PowerPoint, and I will do that. Repatriation cases. Many times we're involved simply to find housing or provide services to a repatriate. Is there any reason namers didn't add a question about repatriation? Repatriation is not officially an APS case. I know that in a lot of counties, in most counties actually, APS workers do the repatriation, but there's no abuse involved. So that's a whole different set of data that goes someplace else. I'm not involved with that. But no, don't count repatriation, folks, here. So I got a question about whether we're talking about the SOC 242 coming soon, and that is true. And the ACL regarding the SOC 242 with all of the definitions and the instructions and the new form will be coming out very soon. But there is also an ACL for the SOC 341, and that is working its way through the system as we speak as well. The new SOC 341 is already available on the CDSS website. You do need to go into the forms, category, and ask for the and then go to the SOC 242. There are some other places on the website that it has not yet been updated, and I need to get that fixed. So you need to look for it in forms. Oh, Dana, thank you. ROA is report of abuse. Okay. I hope I answered that question. I'm not used to that acronym. I think I covered it though. If a client has a behavioral condition, do you also want us to check that they have a disability? It depends on which behavioral condition it is and whether it's interfering with their life, if that makes sense. So people could be in both, but in some cases they will only have the behavioral condition, and you might not have to mark it as a disability. Are we keeping the APS case open after it's been referred to the public guardian office? I would refer you back to your county's policies and procedures about how you're handling those cases. That we are counting in the SOC 242, we're counting whether it's referred over, and we're counting whether there's a conservatorship at the end of the case, at case closure. This is not making any kind of a policy determination about whether you have to keep the case open or not. Okay, would an LCSW who works with children exclusively or a CPS worker be considered a community professional, given that their training is not with older dependent adults? Dana, you have some good questions. If they're reporting on a client who is a disabled, let's say a disabled 19-year-old former foster kid who's aging out, then I would say yes, you would call them a community professional. If they're not reporting on their own client, I'm not sure you, in that case, you would be counting them as a social worker, I think, and leaving it at that. The next question is, will LEAPS upgrade to accommodate this new information? I have been working with all of your different IT folks. There are actually 8 different case management systems in the state of California, which is why I'm not showing you, where on your case management system you are going to be finding this information, because for all 8 systems, it will be somewhat different. They have all been working feverishly to have this ready for you to start using all these new categories as of January 1st, which is when this goes into effect. So yes, LEAPS will be upgraded to accommodate this new information, as should all the case management systems across the state. Let's see, I got to scroll down. Okay, someone said, for repatriation cases that come to their county, we categorize it as self-neglect so that we can provide services. There would not be another way to differentiate these cases, and they would go into general stats, I believe. If you can make the justification that they're self-neglect cases, then you would treat them as ordinary self-neglect cases and report things just like you would in self-neglect. Sometimes financial institutions have an internal process to not report to APS and instead report to their management or the fraud department, who then decides if it gets reported to APS. Who should we report that to? I would talk to your manager if that seems to be an ongoing problem in your county with a specific bank, and then your county managers can talk to me and we can figure out if there's a way to work with that bank for them to do a better job of getting us the information we need. All right, any last questions? Because that's the last one on the list I have. Just leave it open for another minute or two so that if anybody does have a last question they want to shoot in there, we can add it in. Otherwise, if all of your questions have been answered, we'll go ahead and close up the webinar. It is going to be recorded. I'm hoping that I did this right and that I can package it and get it ready to post on the website. It's my first time doing this. I don't know how long it'll take to get it up. Hopefully not too long. And I will also send out the PowerPoint so you have that. I will say your best place at this point to get information is the FAQs, frequently asked questions, that I sent out to you when you, I think I sent it out Monday or Tuesday of this week. And I would go there because we tried to put the answers to all of these kinds of questions in pretty simple English. If you do still have questions, send them to me, lori.delagrammaticus@dss.ca.gov, and I will do my best to answer you directly and then get the things added to the FAQs. Okay, one more thing. Somebody said one more thing, and so I'm waiting to see what that one more thing is, and I will answer that last question. I gotta thank you. You're very, very welcome. I hope this worked. And again, any questions you have, please reach out to me. Look at the FAQs, reach out to me, and I will do my best to get you answers as on a flow basis, because we're all learning this together. We're testing all of this out to make sure it works, and we may have to make some slight tweaks, but we have to have a starting point. And I so appreciate all of you being on the call and watching the webinar in order to get us started in having some really consistent data that will help us really show who our clients are and the work we do, and we will take it from there. All right. Again, thank you all, and given that this is the week before Christmas vacation for lots of people, happy holidays. I'm going to stop the recording now and say goodbye.